with something challenging or negative, the only response to it really is patience and love and kindness.
Supermodel Kendall Jenner is opening up about her struggle with a condition that affects millions.
I feel distant and out of it all the time, and my anxiety is just crazy.
The reality star says she's always struggled with anxiety and hypochondria.
Hi everyone. Welcome to the video. Those celebrities, just like many other people across the globe, suffer from anxiety disorders. Globally, an estimated 3.76% of the population experienced anxiety disorders in 2017, making it the most prevalent mental health disorder. Today, we, the members of Group F, will take you through the pharmacology and pharmacotherapy of generalized anxiety disorder, which is a type of anxiety disorder. First off, let us explore the term generalized anxiety disorder. What? We may all be familiar with the word anxiety, which is a feeling of worry, nervousness, or unease. Occasional anxiety is an expected part of life. For example, you might feel anxious before giving a speech. However, anxiety disorders differ from normal feelings of anxiousness. Anxiety disorders involve excessive fear or anxiety. There are many types of anxiety disorders, including panic disorders, generalized anxiety disorders, phobic disorders, obsessive-compulsive disorders, post-traumatic stress disorders, and other related disorders. Generalized anxiety disorder, or GAD in short, is a disorder that is characterized by excessive, long-lasting and unreasonable anxiety about a number of everyday things like money, family, work and relationships. The anxiety in GAD is not focused on any one object or situation. GAD can be diagnosed based on the criteria in the Diagnostic and Statistical Manual of Mental Disorders. For GAD to be diagnosed, the criteria that need to be met are the presence of excessive anxiety and worry about a variety of topics, events, or activities. The worry occurs more often than not for at least 6 months and is clearly excessive. The worry is difficult to control, and may easily shift from one topic to another. For adults, the anxiety and worry are accompanied by at least 3 physical or cognitive symptoms. In children, only one symptom is necessary for a diagnosis of GAD. You can use the mnemonic C first to remember the symptoms for a diagnosis of GAD. C stands for concentration in impaired concentration. F is for fatigue. I stands for irritability. R is for restlessness. S stands for sleeping disturbance. And T is for tension in muscle tension. The emotional symptoms include constant worries running through the head, feeling like your anxiety is uncontrollable and there is nothing you can do to stop the worrying, disruptive thoughts about things that make you anxious. You try to avoid thinking about them but you can't. And an inability to tolerate uncertainty. You need to know what's going to happen in the future. The behavioral symptoms include an inability to relax, enjoy quiet time or be by yourself, difficulty concentrating or focusing on things, putting things off because you feel overwhelmed, and avoiding situations that make you anxious. The physical symptoms include feeling tense, having muscle tightness or body aches, having trouble falling asleep or staying asleep because your mind can't stop worrying, feeling edgy, restless or jumpy, stomach problems, nausea, and diarrhea. The cause of GAD is not completely understood, but it is likely that GAD results from a combination of factors including genetic, biological, environmental, psychological, and developmental factors. The following risk factors may increase the risk of its development. First is genetics. GAD may run in families. Next, being a female, as women are 2 to 3 times more likely to suffer from GAD than men. Besides, personality. A person whose temperament is timid or negative or who avoids anything dangerous may be prone to GAD. Medical conditions are also one of the risk factors. Some medical conditions such as substance abuse and withdrawal can increase the risk of developing GAD. Lastly, environmental factors, trauma and stressful events such as abuse or death of a loved one can increase the risk of GAD. The pathophysiology of GAD involves a disruption in the normal processing of fear, anxiety and worry in the brain. First, let's look at the role of the amygdala in GAD. The amygdala is the primary modulator in the processing of fear and anxiety in the brain. Here is how the amygdala processes fear and anxiety. The amygdala receives sensory input from areas of the brain such as the sensory thalamus, sensory cortex, and prefrontal cortex. When the amygdala is activated, it stimulates regions of the midbrain and brainstem, causing the activation of the sympathetic nervous system, which causes the physical symptoms of fear. Overactivity in the amygdala may produce excessive feelings of fear. Next, let's explore the role of the corticostriato-thalamo-cortical circuitry (CSTC).
So what is your name?
My name?
Yes, your name.
My name is Osas.
The CSTC is a neurotransmitter circuit in the brain which may be involved in regulating worry. The overactivation of the CSTC may lead to excessive worry. Third, let's look at the neurotransmitters that pass messages between neurons in the amygdala-centered neurotransmitter circuits and the CSTC. In GAD, there are also abnormalities in several neurotransmitter systems in these regions. The neurotransmitters systems involved include norepinephrine, serotonin, dopamine, and gamma-aminobutyric acid (GABA). Other neurotransmitters and peptides, such as corticotropin-releasing factor, may be involved. Next, let's look at the sympathetic nervous system. Peripherally, the sympathetic nervous system mediates many of the peripheral symptoms of GAD. The types of treatment available for GAD include self-management, psychotherapy, and pharmacological treatment. First, let's look at self-management. Self-management includes changes in diet and nutrition, regular exercise, using relaxation strategies, learning new problem-solving strategies, and joining support groups. Next, let's look at psychotherapy. Psychotherapy involves working with a therapist to reduce anxiety symptoms. Cognitive behavioral therapy is one of the most effective forms of psychotherapy for GAD. Patients work with a therapist to recognize any unhelpful thinking and behavior patterns that are contributing to their anxiety, and make changes to replace these with new ones that reduce anxiety and improve their coping skills. Next, pharmacological treatment is available. This involves the use of medications. The medications that can be used in GAD are benzodiazepines, busparone, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and pregabalin. The first drug class is benzodiazepines. Benzodiazepines are a group of drugs often prescribed to people with GAD. They are optimal only for short-term relief of anxiety. Long-term use of benzodiazepines is not recommended because they are associated with the development of tolerance, psychomotor impairment, cognitive and memory impairments, physical dependence and a withdrawal syndrome. Now, let's proceed to the mechanism of action of benzodiazepines. Benzodiazepines act on a specific type of postsynaptic GABA receptor known as the GABA-A receptor. As shown here, the GABA-A receptor is composed of 5 alpha, beta and gamma subunits. When GABA binds to its receptor, the central chloride ion channel opens and negatively charged chloride ions enter the cell. Benzodiazepines bind to the GABA-A receptor at the benzodiazepine binding site, which is different from the GABA binding site. Upon binding, benzodiazepines change the shape of the GABA-A receptor and cause GABA to be more strongly attracted to bind to its binding site. This increases the frequency of opening of the chloride channel produced by GABA and more negatively charged chloride ions enter the neuron. The inside of the neuron becomes more negatively charged, making them harder to excite. It becomes more difficult for excitatory stimuli to trigger action potentials. Therefore, benzodiazepines reduce transmission of impulses in the parts of the brain involved in fear, anxiety and worry, and reduce anxiety. Some examples of benzodiazepines commonly used in anxiety include alprazolam, clonazepam and lorazepam. Alprazolam is a short-acting high-potency benzodiazepine. It has an elimination half-life of 6 to 27 hours. Due to its short elimination half-life, a common issue with alprazolam is that abrupt discontinuation causes rebound anxiety, which is the temporary return of greater anxiety symptoms that occurs with abrupt discontinuation of a drug treatment. Next, clonazepam is a high-potency benzodiazepine. It has a long elimination half-life of 30 to 40 hours. Due to its long elimination half-life, it does not cause rebound anxiety. Clonazepam has low lipid solubility, hence it is less likely to cause anterograde amnesia compared to the other high-potency benzodiazepines. Anterograde amnesia is the loss of the ability to create new memories, leading to a partial or complete inability to recall the recent past. Lorazepam is a short-acting high-potency benzodiazepine. It binds to the GABA-A receptor with less affinity than alprazolam but with greater affinity than clonazepam. It is slightly less lipid-soluble than alprazolam, hence it has lower risk of amnesic side effects compared to alprazolam. Lorazepam undergoes direct glucuronidation without prior cytochrome P450 metabolism. Therefore, lorazepam can be used in patients with hepatic or renal dysfunction with only minor effects on the drug's pharmacokinetics. Let's move to the side effects of benzodiazepines. Common side effects of benzodiazepines include drowsiness, lethargy and fatigue. At higher dosages, impaired motor coordination, dizziness, vertigo, slurred speech, blurry vision, mood swings, and euphoria can occur, as well as hostile or erratic behavior in some instances. They may impair driving and they are often associated with falls in the elderly, resulting in hip fractures. Benzodiazepines are eliminated slowly from the body, so repeated doses over a prolonged period can result in significant accumulation in fatty tissues. Thus, some symptoms of overmedication such as impaired thinking, disorientation, confusion, and slurred speech can appear over time. Tolerance, dependence, and withdrawal are adverse effects associated with long-term use. The next drug used in the treatment of GAD is busparone. It is used as a second-line agent after selective serotonin reuptake inhibitors or SSRIs. When a patient does not respond to or cannot tolerate the side effects of SSRIs. Busparone can also be used together with SSRIs. Busparone is FDA approved for both short-term and long-term treatment of GAD. Unlike benzodiazepines, it is not associated with a risk of physical dependence or withdrawal. However, it takes 2 to 4 weeks to work and is not effective for short-term or as needed treatment of acute anxiety states. Let's now discuss the mechanism of action of busparone. Busparone is thought to target presynaptic and postsynaptic serotonin 1A or 5-HT1A receptors in the parts of the brain that regulate fear and anxiety. The presynaptic 5-HT1A receptors are inhibitory autoreceptors, which means that when they are activated, they inhibit the firing of serotonergic neurons. Busparone is a full agonist at the presynaptic 5-HT1A receptors. Busparone initially activates these receptors and decreases the release of serotonin. However, over time, busparone causes desensitization of these receptors. This causes increased excitation of the serotonergic neurons and causes them to release more serotonin. This may explain why busparone takes 2 to 4 weeks to start working. Besides, busparone is also a partial agonist at postsynaptic 5-HT1A receptors. In a nutshell, busparone enhances serotonergic activity in the brain areas responsible for fear and anxiety. Busparone also has a weak affinity for serotonin 5-HT2 receptors and acts as a weak antagonist on dopamine D2 autoreceptors, although there is not much evidence that the action at these receptors contribute to the anxiolytic effect of busparone. It may also bind to alpha-1 adrenergic receptors as a partial agonist. That's all about the mechanism of action of busparone. Now let's discuss more on busparone's administration. Busparone is available in 5, 7.5, 10, 15, and 30 mg oral tablets. Patients should be advised to take busparone consistently either with food or without food. This is because food intake decreases absorption but also decreases the first-pass metabolism of the drug. The net result of taking busparone with food is an increase in its bioavailability. Next, let us look at pharmacokinetics of busparone. Busparone has an average elimination half-life of about 2 to 3 hours. It is metabolized in the liver by cytochrome CYP3A4, and this gives rise to possible drug-drug interactions. For example, rifampicin causes decreased plasma levels of busparone while itraconazole causes increased plasma level of busparone. Busparone is excreted by the kidneys. The bioavailability and half-life of busparone is increased in patients with liver impairment or renal impairment. The most common side effects associated with busparone are dizziness, nausea, headache, nervousness, lightheadedness, excitement, and insomnia. Other important but less frequent side effects include unsteady gait, diarrhea, weakness, hostility, skin rash, and tremors. That's all about busparone. Next, selective serotonin reuptake inhibitors or SSRIs in short are also used in the treatment of GAD. SSRIs are antidepressants but they are also used in GAD as the first line of treatment. However, they are only effective in some people, and it usually takes 2 to 6 weeks for SSRIs to start reducing the anxiety. Next, let us move to the mechanism of action of SSRIs. SSRIs act on presynaptic serotonergic neurons in the brain. When SSRIs are not present, after serotonin is released into the synaptic cleft, it will be taken back into the presynaptic neuron by the serotonin reuptake transporter. It is then degraded. When SSRIs are present, SSRIs bind to the serotonin reuptake transporter and block it from transporting serotonin back into the presynaptic neuron. Hence, serotonin will accumulate at the synaptic cleft and there is more serotonin to bind to postsynaptic neurons. This helps improve anxiety symptoms. Some examples of SSRIs that are used in GAD are citalopram, escitalopram, fluoxetine and paroxetine. Rarely, SSRIs can cause serotonin syndrome. Serotonin syndrome occurs when too much serotonin accumulates in the body. Serotonin syndrome most often occurs when two medications that raise the level of serotonin are combined. These include, for example, other antidepressants such as selective norepinephrine reuptake inhibitors, tricyclic antidepressants, or monoamine oxidase inhibitors, and certain pain or headache medications such as triptans. Signs and symptoms of serotonin syndrome include, anxiety, agitation, high fever, sweating, confusion, tremors, restlessness, lack of coordination, major changes in blood pressure and a rapid heart rate. Next, stopping SSRI treatment abruptly or missing several doses can cause withdrawal-like symptoms or discontinuation syndrome. This can include a general feeling of uneasiness, nausea, dizziness, lethargy, and flu-like symptoms. Now, let's discuss possible drug-drug interactions of SSRIs. SSRIs may increase risk of bleeding, especially when the patient is taking other medications that increase the risk of bleeding, such as nonsteroidal anti-inflammatory drugs, aspirin, warfarin, and other blood thinners. The side effects of SSRIs include feeling agitated, feeling or being sick, indigestion, diarrhea or constipation, loss of appetite and weight loss, dizziness, blurred vision, dry mouth, excessive sweating, headaches, difficulty sleeping or drowsiness, and sexual dysfunction. The next drug class used is serotonin norepinephrine reuptake inhibitors, or SNRIs in short. The SNRIs are also antidepressants but they are also used in GAD as a first-line treatment. The effect of SNRIs in anxiety reduction occurs after a week or 10 days. Basically, the mechanism of action of SNRIs are similar to SSRIs in the treatment of GAD, but SNRIs block both the serotonin transporter and the norepinephrine transporter. Hence, they inhibit the reuptake of serotonin and norepinephrine. This causes both, serotonin and norepinephrine to accumulate in the synaptic cleft. Similarly, the increased serotonin levels help improve anxiety symptoms. Some examples of SNRIs used in GAD are duloxetine and venlafaxine. Like SSRIs, SNRIs can increase the risk of bleeding and may cause serotonin syndrome. Stopping SNRIs abruptly or missing several doses can cause withdrawal-like symptoms. Let's proceed to the side effects of SNRIs. Because SNRIs target norepinephrine receptors as well as serotonin receptors, SNRIs tend to have more side effects than SSRIs. Venlafaxine may increase blood pressure while duloxetine may worsen liver problems. Other side effects of SNRIs include feeling agitated, feeling or being sick, indigestion, diarrhea or constipation, loss of appetite and weight loss, dizziness, blurred vision, dry mouth, excessive sweating, headaches, difficulty sleeping or drowsiness, and sexual dysfunction. Another drug used in GAD is pregabalin. It is a structural analog of GABA, but it does not bind to GABA receptors. Let's discuss the mechanism of action of pregabalin. Pregabalin targets voltage-gated calcium channels of overexcited presynaptic neurons. Without the presence of pregabalin, calcium influx triggers the release of excitatory neurotransmitters from the presynaptic neurons which stimulate postsynaptic neurons. When pregabalin is present, it binds to the alpha-2 delta subunit of the voltage-gated calcium channels of overexcited presynaptic neurons. This prevents calcium influx and results in a reduction in the release of excitatory neurotransmitters such as glutamate and substance P, which causes reduced stimulation of postsynaptic neurons, hence reducing anxiety. Next, pharmacokinetics of pregabalin. Pregabalin is absorbed rapidly when given on an empty stomach. When given with food, pregabalin is absorbed slower but the extent of absorption is unchanged. Pregabalin is highly lipophilic and readily crosses the blood-brain barrier. Pregabalin has no active metabolites, does not inhibit or induce cytochrome P450 enzymes, and its pharmacokinetic properties are not altered by CYP enzyme inhibitors. Pregabalin is mainly eliminated unchanged renally, hence dosage needs to be reduced in patients with renal impairment. The side effects of pregabalin include drowsiness, dizziness, headache, dry mouth, nausea, constipation, and weight gain. That's all about the treatments used for GAD. Lastly, let's have a summary of the pharmacological treatment of GAD. This video showed 5 types of drugs used to treat GAD. You can remember them using this mnemonic. Ben caught the bus to see the scenery but he got pregnant instead. Ben represents benzodiazepines. Bus represents busparone. C represents SSRI because SSRI sounds a bit like C when it is pronounced. Scenery represents SNRI because they both have the letters S, N and R, and pregnant represents pregabalin as both pregnant and pregabalin starts with PREG. Besides, pregabalin acts on the alpha-2 delta subunit of voltage-gated calcium channels to inhibit excitatory neurotransmitter release. You can also remember that the Greek symbol for delta looks like a pregnant woman. The first drug, benzodiazepines, increases the frequency of opening of chloride channels caused by GABA. The 3 drugs in the middle, busparone, SSRIs, and SNRIs have mechanisms of action related to serotonin. Busparone acts on 5-HT1A receptors to enhance serotonergic activity. SSRIs only inhibit the reuptake of serotonin while SNRIs inhibit the reuptake of serotonin and norepinephrine. And with that, we end our video. We hope this video helped you understand a little more about the pharmacology and pharmacotherapy of GAD. Thank you for watching and have a nice day.